Well, good afternoon and good morning to those of you on the West Coast. We will get started at the top of the hour. Thank you for being here today. Well, it's 1 o'clock, so we are going to go ahead and get started. Welcome to our HPV Provider Series live panel discussion. We are so grateful you have chosen to spend the next hour learning, and we hope you find this session informative and inspiring. I'm Melissa Santiago, HPV Program Manager at the American Cancer Society, and I am honored to be co-moderating today's session along with my colleague, Katie Crawford. Before we get started, I'd like to review just a few housekeeping items. Next slide. Today's webinar provides continuing education for providers, pharmacy, and nursing. A reminder, if you did not register for the series, you will need to in order to receive CME, CNE, and pharmacy continuing education credits. Our session today will be recorded, and the link to view the recording will be shared with all of those who have registered for the series. If you have any issues during today's seminar or have any questions for our presenters, please use the chat feature. And lastly, to ensure there are no disruptions during the presentation, all of our participants have been muted. We will be spending the next hour having an open dialogue with our esteemed panelists, who I will introduce shortly, and spend the majority of time giving you all the opportunity to ask our panelists your burning questions. One final reminder is the HPV video series is live and accessible to all of those who have registered. And after the call, an email reminder with the link will be shared again. And before we get started, I'd like to take a moment to acknowledge and express my heartfelt gratitude to the incredible team who has made this HPV Provider Series come to life. From the Roundtable team, we have Gabrielle Darville-Sanders, Christina Turpin, and from the ACS side, we have Katie Crawford. Thank you all for your support and hard work throughout this process. I'd also like to give recognition to Lori Lovett from the Indiana Immunization Coalition, who has been an incredible partner throughout this process. Thank you all for your leadership. Now it is my distinct honor and privilege to welcome you all to the live panel discussion. Throughout this discussion, we'll explore the importance of HPV vaccination and initiating at age 9, share ongoing research in the HPV field, and explore opportunities to increase vaccination in our communities. I invite the audience to actively engage with us by sharing your questions and thoughts using the Q&A feature. We have the privilege of hearing from a distinguished panel of speakers who are thought leaders, experts, and change agents in the field of HPV. So without further ado, let us give a warm and enthusiastic virtual welcome to our esteemed panel of speakers. Joining us from session 3, Current HPV Vaccine Guidelines and Why Age 9 Matters, we have Dr. Sean O'Leary, Professor of Pediatrics at the University of Colorado School of Medicine and Children's Hospital in Colorado. He is also the chair for the Committee on Infectious Diseases at the American Academy of Pediatrics. Also from session 3, Dr. Debbie Saslow, Strategic Director of Screening and Vaccination at the American Cancer Society. Joining us from session 4, HPV Disparities and Unique Populations, is Dr. Benjamin Peter, Associate Professor at the Center for Implementation Research at the University of Arkansas College of Pharmacy. And finally, Dr. Milky Vu, Assistant Professor at the Department of Preventative Medicine, Feinberg School of Medicine at Northwestern University. If you could all join us on video, thank you so much for being here today. You all represent such a diverse range of experience and expertise, and we are so incredibly fortunate to have you share your wisdom with us today. Our goal is not just to exchange knowledge, but also foster a constructive dialogue that sparks innovation and collaboration. So I encourage everyone to listen with an open mind, ask thoughtful questions, and challenge assumptions respectfully. We will be going back and forth between the audience questions and facilitated discussion. So I'm going to kick us off and keep us on track. This question will be for all of our panelists. Today is our official kickoff of the HPV Provider Series, and many of our wonderful audience most likely has not had the opportunity to view all of your videos. Can you give the audience a sneak peek and a Twitter version of some of the highlights from your presentations? Dr. Saslow, I'll start with you and then move on to Dr. O'Leary, Dr. Teeter, and Dr. Root. What can the audience expect?
Sure. So my presentation is on the benefits of starting HPV vaccination at age 9. The presentation itself is 9 benefits of recommending routinely starting at age 9. And I will say there are 2 highlights. If I wanted you to remember 2 things. One is, out of all 9 reasons, I think the most important one is less shots per visit. And so I think a lot of health professionals may not appreciate that the average parent thinks with their child, 1 shot in each arm and I'm out of here. So age 9, that's a huge benefit. There's no other vaccines that are routinely recommended at age 9, unlike 11, 12, when we have 2 other adolescent vaccines, not counting flu and COVID. And the second highlight is, as a scientist, we're not supposed to talk about benefits without talking about the downsides. So here are the downsides of recommending vaccination at age 9. There aren't any.
Thank you for sharing. Dr. O'Leary?
Yeah, thank you. And my presentation or my video is similar in terms of some of the things we emphasize. What I focus on is why the American Academy of Pediatrics decided to actually change our recommendation. So just as some background, the U.S. Vaccine recommendation process is generally harmonized between the Advisory Committee on Immunization Practices, which advises CDC, and AAP, which I should say the Committee on Infectious Diseases, which advises AAP. And those recommendations are generally identical. And so we really try to keep them harmonized just to avoid confusion for clinicians. This was a case where we decided to be a little bit different than ACIP. And so our official recommendation, beginning with the Red Book, which is our policy, our infectious diseases policy book for the Academy, states that the American Academy of Pediatrics and ACIP of the CDC recommend routine HPV vaccination for females and males. The AAP recommends starting the series between 9 and 12 years at an age that the provider deems optimal for acceptance and completion of the vaccination series. When we made that change, we also provided a fair bit of education to our membership to emphasize, kind of explain what's the reasoning behind that. Honestly, I can summarize the discussion, and I'll go into individual points really quickly as something that Dr. Zaslow just referred to as, why not? We were, at the time, we were facing really suboptimal HPV vaccination coverage, which we still are, but we're doing better now than we were then. And we said, okay, what can we do from a policy standpoint to increase uptake of HPV vaccine? And this seemed like kind of an obvious choice. We were aware of some observational data suggesting that uptake might be better. And then we considered a lot of different things in terms of, what are the potential benefits. Offering the vaccine earlier allows providers flexibility in introducing the vaccine. And then really importantly, as Dr. Zaslow pointed out, 11-year-olds, 12-year-olds may not want 3 or 4 or even 5 shots at a single visit. And what we knew at the time, and is still true, is that if a vaccine is delayed at that 11 or 12-year-old visit, it is almost always the HPV vaccine. And we saw that as a real problem. We're also aware that a lot of clinicians were reporting that starting the vaccine earlier made it easier to disentangle the vaccine recommendation from the discussions of sexuality that they may be having at 11 or 12, which was a known barrier for providers. We also recognized that changing the timing of that recommendation may help with some of the HPV vaccine hesitancy fatigue we were hearing about from pediatricians. Basically, pediatricians were going into visits almost assuming that people would refuse the vaccine at 11 or 12, and because they were getting used to people putting it off. And so we knew that might also get around that particular issue. And then finally, we really couldn't identify any important time. We knew that the Melissa, I think you're muted.
I think Melissa is having some technical, but Dr. O'Leary, I think we missed the end of what you were saying. It cut out a little bit.
Oh, I'm sorry. Can you hear me now?
Yeah, you sound great.
Okay, where did I get cut off?
I think it was like the last sentence.
Oh, I think I was just saying I'll pass it off to the next speaker. So
perfect.
I think I was next. So I guess my video talk is really about some ongoing research in rural populations as they have vaccination disparities, particularly for HPV vaccine. So the way that we have been trying to address that is utilizing rural community pharmacies. In the US, there's 90% of people live within 5 miles of a community pharmacy. And there are less and less pediatricians in rural areas, and even the family medicine clinics are participating less in childhood immunizations. So having access to the vaccine is difficult. So the research that we've been working on is looking at innovative ways to reach these rural populations with pharmacists, and doing that by having collaborations between physicians and community pharmacists to vaccinate these children. So basically, looking at different implementation strategies to get these collaborations set up and implemented in these rural areas.
Thank you so much for that, Dr. Teeter. That was really helpful. I know that Melissa's trying to get back in. It seems that Zoom is not working in our favor today. I am also having some issues, so we apologize for that. So thank you again for sharing your start. That was a great start for our discussion today. We've been looking at some of the questions that are coming in, so I want to go ahead and address as many of those as we can, but we do ask that you keep submitting them. We're getting them both in the chat and in the Q&A. It'd be most helpful if folks could keep those to the Q&A for us to help monitor, but we will certainly try to manage both of those.
Katie,
yes.
1 second. Dr. Vu was unable to share her highlights from her presentation.
Oh, thank you so much, Melissa. I'm going to pass it over to Dr. View, and then Melissa, I'll let you take back over. Sorry about that.
No worry. Thank you, Katie and Melissa. So my presentation focused on issues of HPV vaccination around Asian American. So the presentation start with the key challenge in understanding health disparities among Asian Americans, and that is the lack of inclusion or data disaggregation in this population. Asian Americans are the fastest growing racial and ethnic group in the US today. The population stands at around 22 millions and are, like I say, growing fast. However, a lot of studies or research either do not provide data for Asian Americans, often include them under other racial and ethnic groups, or frequently lump many Asian origin groups under one category. So the goal of the presentation was really to review the evidence on the heterogeneity in HPV-related cancers as well as HPV vaccination in this population. So I talk about the evidence that came out in recent research studies. I also talk about a systematic review that I led that include 26 studies on HPV vaccination determinants in Asian American populations using a multi-level framework. Then the presentation also talk about the current development in strategies to increase HPV vaccination for Asian American groups. And there have been best practices that are developed around what clinics or health systems can do to boost HPV vaccination, which are really important because much of vaccination is still happening inside the clinic or health systems. However, what I try to also emphasize is complementary community engaged approach in addition to these best practices inside the clinics. So what can we do with community outreach to help individuals become more aware of the vaccine, know more about it, and increase community demand for it? And then the presentation concludes with recommendations. So for advocacy for data disaggregation and inclusion of Asian Americans in research studies. I also talk about the need for healthcare providers to be aware of the heterogeneity in HPV vaccination knowledge and uptake in Asian American communities, the consideration of how cultural beliefs, context, immigration status, English language proficiency, and other sociocultural factors might influence HPV vaccination. And really the need for partnerships with trusted community agencies and messengers to deliver culturally tailored and linguistically appropriate interventions, and leveraging digital health technologies when appropriate for health promotion tools. Thank you.
Thank you, Dr. Rue. I've had a chance to view everyone's video, and I hope this just made everyone excited to learn more about your respective topics. So I think we're ready for our audience. Katie, do we have our first question?
Yeah, so we have a question from Melissa. She is asking, for us as providers and from a public health standpoint, it makes sense to do it at 9 for all the reasons that I believe Dr. Teeter, Dr. O'Leary was saying. Can we cite the data for why it's better in terms of your immune system at 9? She says, I know the data is evolving. So any specific data that we could cite for her would be helpful, it sounds like.
Debbie, you want me to take this one? Yeah, so the studies were done, the original studies in the US, and then there were studies internationally looking at the immune response in children 9 to 14 and then 15 to, I believe, 26. And it was shown that if you got the vaccine in the younger age group, your immune response was actually better than in the older age group. And then when you drill down further on those data, the immune response at age 9 and 10 was really the most robust. And so I think I hesitate to overstate that too much, because this is such an incredible vaccine in terms of the immune response that it gives at pretty much any age, really. We talk about correlates of protection for vaccine preventable diseases. And what that means is, what is the level of protection we need based on certain measures. Often it's an antibody measure that we know will protect from disease. We actually don't know what that number is for HPV, but we believe that it is far lower than what we get from these vaccines. So this particular vaccine is unusual in that the vaccine actually does a better job protecting our immune systems than natural infection. So to say that another way, if you get infected with HPV, it doesn't actually give you that robust of an immune response. But if you get vaccinated with HPV vaccine, it gives you a very robust immune response. And so we know based on these studies that the immune response at age 9 or 10 is very, very good, and it lasts for a long, long time, many years. And we're continuing to measure how far out that goes from the original studies.
Dr. Saslow, do you want to weigh in on anything?
No, I think that was a pretty comprehensive answer.
Excellent. Well, keeping with the theme of age 9, we know that initiating at 9 is not new, but there seems to be stronger emphasis from ACS, AAP, and other organizations. But we still find that providers are hesitant or apprehensive. I'd love to hear from Dr. O'Leary and Dr. Saslow. What is the evidence telling us about age 9? And is this consistent with CDC and ACIP guidelines?
I can start on that one. When AAP and ACS updated our guidelines a few years ago, I think there were 4 or at most 5 references that we were citing, and they were really good studies. But we had heard and knew ourselves that we needed more evidence. And so the National HPV Vaccination Roundtable set that as a goal for itself last year. And hopefully someone can put in the chat a link to a journal supplement that by the time of the published studies and the ones that are about to be published, we have an additional 24 peer-reviewed articles just on age 9. So an entire supplement just on age 9. They run the gamut, all, short articles, commentaries, research, different parts of the country, national, survey, observational. There's something for everybody. And then also on the Roundtable's YouTube channel, there are abstracts, video abstracts from the authors, starting with our own Dr. O'Leary, for many of those articles if you want to get a quick snapshot. So I would say that the evidence base has recently gone from small but strong to quite large and stronger.
And just to add, similar, when we made the change with AAP, we had roughly about 5 observational studies, basically showing that with retrospective data, meaning looking back in the past, that when clinicians initiated the vaccine at age 9 or 10, they tended to have higher completion rates than if they initiated at 11 or 12. And some of the results were quite striking in terms of the difference there. We actually have right now, because to my knowledge, there aren't any large randomized controlled trials looking at this question. We actually have a large randomized controlled trial here in Colorado with colleagues in Southern California, where we have randomized pediatric practices for training either in how to introduce HPV vaccine at age 9 or 10 versus introducing it as the usual care at 11 or 12. And we should have results from that study late 2024, early 2025.
Thank you all for your thoughts. I know, Katie, we've been getting lots of questions in the Q&A feature, so why don't we take an audience question?
Yeah, so this is for Dr. Teeter. Sharon is wondering, Dr. Teeter, are you looking into utilizing LBOH and school nurses to assist with vaccination in rural areas?
Sure, yeah. So local health units are the sole resource for HPV vaccination in a number of counties in Arkansas, where I'm conducting research. We haven't partnered with those units for ongoing research, but definitely think that it'd be beneficial the same way that we're partnering pharmacists and pharmacies with family medicine clinics. We are partnered with some FQHCs to provide vaccine, but right now we haven't partnered with those local county level health units. For school nurses, I know there are people looking at that. Personally, I'm not doing research in that area, but I think that's a great place to explore. What we've found in a lot of our research is there's some pushback to doing that in schools. Just parents being concerned with school nurses messaging without them being there. But I think partnering and maybe having referrals from, could be something that would be beneficial. We are looking at, collaborations with pharmacists and dental clinics. We're also looking at embedding community health workers in community pharmacies to go out in the communities they live in and provide outreach and education, and then refer back to pharmacies for immunization. But right now, as far as school nurses and local health units, I'm currently not conducting that research.
Thank you, Dr. Treater. Shifting gears now, moving over to you, Dr. Vu. Your presentation had an emphasis on the Asian American community. What are some common myths or misconceptions associated with those communities concerning HPV vaccination, and what can providers do to counteract some of those during their day-to-day practice?
Thank you for that really important question. So I can certainly speak about the myths or misconceptions and sort of from both viewpoints. So first, from the viewpoint of the public towards Asian American health, focusing on HPV vaccination and HPV-related cancer. And then regarding the perceptions that we've noted in our community engaged research that some Asian adults or parents have expressed towards HPV vaccination. So again, like I mentioned in the video, I really tried to make the point that one of the biggest challenge with increasing HPV vaccination in Asian community is the myth or misconception that Asian populations do not experience health disparities. In reality, they do. And so, for example, while cervical cancer incident rates of aggregated Asian population are lower than that of non-Hispanic white counterparts, disaggregated data show that several origin groups, such as Vietnamese adults, actually experience higher cervical cancer rates than non-Hispanic white counterparts. However, because of the model minority myth that often portray Asian American as a homogeneous group that experience high level of socioeconomic success and little structural racism or disadvantage, there's very little attention focusing on this population and like a resource of funding or health promotion targeting them. And a lot of health systems currently do not disaggregate data of patients' race or ethnicity to the level of origin groups such as Vietnamese, Korean, Chinese, Asian, Indian, or Filipino, etc. And therefore makes it very hard for us to understand these disparities. So that's the first part. And then the second part that I want to talk about is from our community engaged work, a couple of issues or questions that we frequently run into. So first, language is very important, especially for Asian immigrants with limited English proficiency. We found out that when we came to the community and talk about the HPV vaccine, a lot of people are not familiar with this term. Like they've not heard of the HPV vaccine before. Sometimes they confuse it with the HBV vaccine, which is for hepatitis B, but sounds incredibly similar to HPV when English is not your first language. Some people are familiar with the term cervical cancer vaccines because that's when the HPV first came out. That's kind of how it was translated in a lot of countries in language. However, what we try to really emphasize is that it does prevent cervical cancer, but not just that. Your males are also eligible to get the vaccine. Your adolescent son can get the vaccine. So I think language and translation is important. Some other questions that have come up again in our research qualitative studies include, was this vaccine developed with the same people or the same group that I came from? How do we know that, for example, it worked as well as in Vietnamese people as in other people? Does its vaccine affect fertility or reproductive health? And then, of course, there's the sexual activity question, which, we get not just for Asian Americans, but other racial and ethnic groups as well. So back to your question. So for providers, I think it's the need to recognize the diversity of the community, advocate for disaggregation of data reporting to identify possible disparities, providing language access, being able to be prepared to respond to the questions about the vaccine that I previously mentioned, and then clearing up information on access as well. So for example, letting parents know that their child or their children, adolescent children might be eligible for the Vaccines for Children program and, can get vaccine at no cost. So those are important things for providers to be mindful of.
Thank you, Dr. Vu. Those are really great tactical things that people can put into practice. I feel like this is such a great start to our discussion, but I'm going to move over and Katie, let's take 2 questions from the chat.
Sure. So Christiane is interested in knowing what what are the top key strategies we can use when working with provider offices to help with education and best practice implementation. So I think this is open to all of the panelists if they've got ideas around this.
Sure, I can kind of start to tackle this one. So a lot of the work I do involves training providers and how to communicate about vaccines and often specifically about HPV vaccine. But that's actually one small piece of a much larger pie. There are lots and lots of evidence-based strategies that offices can use to increase vaccination coverage. And it's lots of different things, that will get you incremental benefit to achieve the high coverage we really need to get. And there are various sources for where to look through all of those. I like looking at the U.S. Community Preventive Services Task Force website, as they list a lot of the strategies and the evidence behind them. The ACS website, of course, has a lot of this, as well as does the AAP website, in terms of the strategies you can use. Things that I think of that work really, really well. So standing orders for vaccination. The rules on those can vary a little bit state by state on how they work, but for the most part, in most states, standing orders are a very effective way to increase vaccination coverage. And I'll just give you one example from here in Colorado. The Denver Health and Hospital Authority is our big safety net system, and they have a large hospital as well as a lot of community clinics, as well as school-based health centers. They made the decision many years ago to really try to take the vaccination discussion out of the clinicians' hands and put it into the hands of the medical assistants and nurses who were administering the vaccines. So they implemented a system of standing orders quite a long time ago, where the nurses and medical assistants are empowered to look up the vaccination records for a child who has an appointment, whether it's a well visit or a sick visit, see what they're due for, and even give that consent and give that vaccine before the clinician has even entered the room. And using that strategy, they can achieve coverage often of greater than 90% initiation in a lot of their clinics, including their school-based health centers. So it's a really effective strategy. I remember my wife is a pediatrician in the Denver Health System, and I remember talking to her about a communication intervention we were going to be designing and implementing within a lot of the private practices here in Colorado. And she said, gosh, I can't even remember the last discussion I had about HPV vaccine. The MAs just do it. And so I think that's one really effective strategy I would highlight. And there's others, reminders and recalls, et cetera. But if I had to name one, I would say probably really implementing a really good, strong standing order policy, getting all of the clinic on the same page with HPV vaccination, empowering the nurses and medical assistants to administer the vaccines. And in many cases, there you can work with them and train them to answer questions from families about vaccines. And I think that actually often increases job satisfaction. And I'll stop there.
Does anybody else want to weigh in on that question?
I'll say quickly, know your rates. I think a lot of providers think that their vaccination rates are a lot higher than they actually are.
Thank you, Dr. Saslow. I'm going to switch, or actually, Katie, do we have another question from the audience we can take?
Yeah, we've got lots. So I think this is going to be for Dr. Vu, but I think maybe Dr. Teeter can also weigh on this a little bit. We have Miranda is interested. Is there any specific data about HPV at 9 in Native American communities?
That's a really important question. I think with American Indian and Alaskan Native communities, there is a very similar issue to Asian American communities in the sense that often because we are considered a small sample size group, data for HPV vaccination, HPV related cancer in these communities are often not included in national reports or research studies. I know, for example, with the National Immunization Survey team, they include data for non-Hispanic white, non-Hispanic Black, and Hispanic adolescents in their public use of data, but they don't provide data for Asian Americans or Native Americans for analysis for researchers. They do include it in the annual report of data. What I remember looking at several years ago is that if you look at the trends of HPV vaccination, Asian Americans and Native Americans are often the groups that have the most unstable trend. So, like the rates kind of move around. One year they're like the lowest group, one year they're the highest group, one year they're somewhere in between. And I think the issue is that they're just not enough of adolescents identifying as Native Americans or Asian Americans that are included in this survey, and therefore they create this unstable trend in data statistics. So there is a very long way to answer the question of, is there any data? To my knowledge, it is included in the NIS team that the CDC, the report that the CDC released yearly, but it's not included in the data set that researchers can use to explore sort of more contextual nuance of, for example, what are what are the rate of provider recommendations, what are some of the contextual factors that might influence HPV vaccination in this population. So I think it's a very important topic to continue to advocate for, like the need for data inclusion and data availability and reporting for these populations.
Thank you, Dr. Vu. Does anybody else want to add anything to Dr. Vu's points? All right, I'm going to shift gears a little bit and focus on parents. There is a lot of misinformation and vaccine hesitancy, even more so now after the pandemic. What is one thing you would tell a parent if they're hesitant about initiating at age 9? I'd love to hear Dr. Saslow and Dr. O'Leary, your thoughts.
I haven't heard much hesitancy about age 9. I think that's one of the benefits. But hesitancy in general, I just keep the message focused on cancer. I don't know any parent that wouldn't want to protect their child against not just one cancer, but 6 types of cancer.
Yeah, and I would say, specific to age 9, I think it depends on the situation. A lot of these depend on the individual conversation. But for if it's a question specifically like from a parent who says, well, 11 to 12 sounds good to me, and I'm not so worried, that I'm not so, I'll get it eventually. then I, would emphasize some of the benefits that you might get from age 9, such as not having to have multiple vaccines at once, getting it done early, those types of things, and then also emphasize the of course the benefits of preventing cancer. I think that's worth, any discussion is worth mentioning that, because that a lot of parents actually don't understand what this vaccine is really for. And then, in general, we did a study here, and it's kind of taken off in terms of use for these conversations on motivational interviewing. So we train clinicians in motivational interviewing for HPV vaccine conversations. And motivational interviewing is basically it's a specific type of communication that is you can train for years and become a total expert in it, or you can receive a very brief training and pick up a few techniques. And I think both are potentially beneficial. What we do is train clinicians in what some people might call brief MI. So just teaching them a few specific techniques. And those are things like when a parent brings up a concern, you simply say, that I understand what you're saying. It sounds like you're worried about, say, the safety of the vaccine. And then another brief MI technique would be to say, would you mind if I shared with you what I found out when I looked into that? And simply asking that question makes people more receptive to what you're then going to say. Now, by no means does it work every time, but that's the concept behind MI, is you're trying to make an individual more receptive to the information that you're then going to share, so that they then make the health behavior change based on their own motivations, for their own reasons, rather than just because you told them to do it.
Thank you both for your insightful contributions. Katie, going back to some audience questions, let's take a couple.
Sure. Okay, so I think that this one might be for Dr. Saslow, but please, we'd love to hear from all the panelists. What do you think of the WHO recommending 1 or 2 doses of HPV for 9 to 14-year-old girls? Will the US be considering a 1-dose regimen? We've gotten a couple of those questions.
So there's a lot of data, and there's more clinical trials underway. I think it would globally be very helpful financially. I mean, there's the countries that have the highest burden of cervical cancer really could use this boost of 1 dose instead of 2. And some other high-income countries have also taken this up. In the US, we follow the ACIP guidelines. So, we have more of an emphasis on gender-neutral vaccination, for example. And I know that the ACIP has looked at the data from the 1-dose trials, and it continues to be on their agenda. They were a bit sidetracked by something called COVID for the last few years. And so we'll see how that goes forward. But the fact that they're looking at the data is a good sign.
Anybody else want to weigh in on that?
Yeah, this was presented at ACIP in a public meeting about a little over a year ago. And the data are very compelling for 1 dose. ACIP going forward, as Dr. Zaslow pointed out, may be bringing this topic up for a vote, actually. And there are a number of trials actually going on right now to look at that, because a lot of the data right now are observational, and we don't have as much long-term data as we do for the 2 or 3 dose regimens. But it is a very compelling issue. The current recommendation, of course, is for 2 doses for healthy children under 15 and 3 for 15 and up. But the way I've been putting it is still follow those recommendations, try to get those 2 doses in, but you can feel really good about getting that 1st dose in.
Thank you, Dr. O'Leary. Katie?
Yeah, so again, this is for all of our panelists to weigh in on. For non-Hispanic Black populations have the highest HPV percentage at 9.7%. Are there any specific strategies being implemented to promote HPV vaccine to this population?
I guess I can jump in and comment. I think, you know, there's a lot of work on HPV vaccine promotion in pretty much any population you can name across the country. I think that, you know, here in Colorado, I can speak to a few specific efforts around community engagement for HPV vaccination. And I know I'm aware that that's going on in a lot of places. So these aren't necessarily big, giant, you know, randomized clinical trials, but they're more working with trusted messengers, working with leaders within individual communities, including non-Hispanic Black communities, to really get at, you know, what are the issues here within this specific community that's preventing people from getting vaccinated. And so there is that kind of work going on there around the country. I know that CDC and ACIP, as well as AAP, are always looking at vaccination disparities and how we can address them. So there is a lot of individual work going on across the country to try and address those disparities for sure. I'm not aware of any sort of systematic, very large trials right now, though, but more a lot of grassroots efforts.
Thank you. Let's keep the questions coming, Katie. We have limited time, so we want to get to as many as we can.
Yeah, so as we're talking about shifting that initial vaccine to age 9, we have Vicky is wondering, she's heard concerns from some about decoupling the HPV vaccine from the meningococcal and Tdap by moving to age 9. How would you respond to those concerns? And Debbie did put a little bit in the chat for this, but I think this is a good one to answer live.
Yeah, I'll just repeat what I put in the chat. If you are a provider, a health system, if you are partnering with a practice and the rates of HPV vaccination are equal to their rates of Tdap and meninge for 11 and 12-year-olds, keep doing what you're doing. That's awesome. But for most, the rates of HPV are lower than for Tdap and meninge for a variety of reasons. And in that case, starting to, if you're not already, offer HPV vaccination at age 9 with the second dose at 10 might bring your rates all the way up. And as an added bonus, the change in HEDIS to sort of get credit for all 3 vaccines instead of each one individually means that if you have rates of say 90%, 85 to 90% for Tdap and meninge, and say 70% for HPV, you only get credit for 70%, not 85 to 90% anymore. So it's in your best interest to get those rates up. But again, we're not saying don't vaccinate at 11, 12 if that's what's working for you. We're saying that if you start at 9, you may boost your rates.
Thank you, Dr. Saslow. Dr. Teeter, I'm coming over to you now. We know that it's so important to voice the community and have them at the table. What advice would you give to engage people in rural communities to inform them of programs and services around vaccinations and HPV-related cancer care?
So some of the things that we're exploring are like the community health worker getting someone that looks like the recipient, right, to go out and kind of promote the vaccine and give the message. You know, we've like you said, it's important to get them involved. We always have them involved when we're creating materials, when we're trying to figure out, you know, how the message needs to be framed. One of the things we have that kind of is related to what Dr. O'Leary was saying, you know, a lot of the evidence has said in the past that, you know, the presumptive method and a strong recommendation are the best ways to improve rates. But what we're finding in a lot of these rural areas, particularly in the South and Southeast, it's better to do something like motivational interviewing, where they will have, kind of control over that decision, and they feel like they're making the choice. They're not being told what to do. So, having them involved, outreach in the community is vital to get interest. There's a lot of gaps in rural communities as far as knowledge of the importance of the vaccine. Rural individuals in general are less likely to seek healthcare. So, really just outreach and being in the community. Those are strategies that we're developing for some of our studies.
Thank you, Dr. Teeter. Katie, let's take as many questions as we can from the audience in the time that we
Got
have.
plenty.
So let's keep them rolling.
All right, Miranda's wondering if there's evidence that HPV vaccine at 9 increases the rates of vaccination. She's looking for specific examples of health systems or states that have done this.
We have tons. So there's a link to the article supplement earlier in the chat. The original peer-reviewed articles that both AAP and ACS cited in our guideline updates were based on some of these health systems. And so the answer is yes, there's quite a lot of evidence. Also, Katie, I don't know if we can provide, but there's recorded webinars from our own HPV team, and I'm remembering one in particular where we had some guests on the webinar, and we asked them, we showed that they increased rates quite dramatically of HPV vaccination during a year's time in the middle of the pandemic. And when we asked them on one of these panel forums, what was like the key to your success, they said age 9. So I'm pretty sure that was one of the New York systems. So lots of data out there. We'd have to pull some of it.
Yes, and we will definitely be sharing all of these resources in our follow-up email so you can have access to all of them.
Hey, Dr. Saslow, this might be another one for you. We're getting questions around therapeutic uses for HPV vaccine. So is there a connection between cervical cancer and fibroids? And can the HPV vaccine prevent fibroids? So maybe talk in a broad nature about any therapeutic natures we know for HPV vaccination.
So there are several therapeutic HPV vaccines in development. I don't know anything about the connection with fibroids. I don't think fibroids are caused by HPV. Anyone else can correct me?
I'm not aware that that's been studied as an outcome.
There are some indications for the preventive HPV vaccine, Gardasil 9. For women who are undergoing LEAP and other precancer procedures, there's some data, I think it's pretty mixed, that it could help prevent a recurrence of that precancer. And then separately from the preventive vaccines, there are completely different vaccines that are in development for therapeutics. And I know that there are a lot of presentations on those at the this year's IPV, International Papilloma Society conference. But as far as I know, there's none that's either approved by the FDA nor really close to approval, but there's a bunch in the pipeline, so we're hopeful.
Great, thanks. Okay,
Can I just say there's a lot of questions about therapeutic vaccines, such as what's the best target? So is it better to target HPV infection, in which case you get it sooner, but you'd need to vaccinate everybody? Would you target precancer? Would you target cancer? So there's a lot of different approaches to developing a therapeutic vaccine.
Great, thank you. We've sort of touched on this throughout the conversation today, but Jennifer is commenting, we hear a lot about the importance of interdisciplinary approaches. What role may a non-provider, clinical, or other staff have in assisting to improve HPV vaccination rates? I think this is an important question to sort of call out, just to highlight that everyone in the office or everyone in the pharmacy has a role to play.
As a non-MD, I'll pass along an anecdote that I've heard several times from Katie, your team, and Melissa's, which is we've heard the story of the parent who walks up to the front desk of the office to check in, and the office staff might say something like, oh, I wouldn't get the HPV vaccine for my kid. So make sure your staff are all on board, because you never know what they're saying.
Yeah, and I have lived through that experience. If a medical assistant or a nurse says anything negative about a vaccine before they come into the room, you're done. So really, it's crucial that everyone is on the same page with these, and so doing little trainings for staff can be really helpful.
Dr. Wu and Dr. Teeter, do you have anything to add to that?
I think that's kind of the angle that we're trying to take with non-clinical staff in a pharmacy, with the community health workers embedded in the pharmacy. It's someone from the community that is there, that has lived in the little town all their lives, and is has a respected opinion. People value their opinion. To just kind of be there to recommend, as a non-clinical person, just saying like, hey, my kid had it and they're doing great, whatever. I think just having, those people in the community, is important.
Thank you. Dr. Wu, did you want to add anything?
I think not much. Of the panelists have made really good points. I would just say that one of the good, if you can call it that, impact of the pandemic is that it has made it much more, as parents are much more aware of vaccination that takes place in the pharmacy setting, and much more accepting of that compared to before the pandemic.
And this is, the perfect opportunity also to just plug in our HPV provider series. Even though it's called for providers, it technically can be shared with anybody, and anybody can view them. So it could be very helpful for staff and your systems and partners to view them. It's open to all. I think we have time maybe for one more quick question, Katie.
Okay, we're seeing this, I'm going to couple this. We're seeing this one over and over. So why not just have a single age recommendation at age 9 instead of the age range for administration? And do we anticipate ACIP to change their language around starting at age 9?
Yes, I mean, to the first one. To the second one, we hope so. I think what I would say, so we are hopeful that, I mentioned our trial where we're comparing in an RCT. I mean, what the explanation we got at when this has been brought up at public ACIP meetings was that the data weren't there to support the change. I tend to disagree with that interpretation of the data, but we're hoping that results from an RCT, if assuming they're positive, would lead them to reconsider. But I think there are a lot of people that are hoping for that kind of a policy change.
You're much more optimistic than I am. We've been pushing, we've really been trying. And I'll just note that the ACIP has not revisited this question since the original recommendation in 2006, 2007.
Thank you all so much for your input. We're going to go ahead and close out this session. I want to thank you all of our panelists, for sharing your time and your expertise and valuable insights. I also want to thank everyone in the audience for your active participation and your insightful contributions throughout the session. It is through collaboration and knowledge sharing that we can make a meaningful impact in the fight against HPV-related cancers. Together, we can create a future where HPV-related diseases and cancers are a thing of the past. So thank you again for your time, and we hope to see you very soon.